like to take a moment just to express my gratitude to the Monteris team. Thank you for inviting me to participate in this lecture, and thank you so much for helping to collect and create the content for the presentation. And my only disclosure is just a consultation agreement that I currently have with Monteris. This is the broader disclosure, which we can forward to you if you have specific questions about use, indications, or contraindications. And then we'll just jump right in. As you remember, LITT is a MR-driven, minimally invasive treatment option. And we primarily use MR data to plan and monitor these treatments. As you remember, LITT is performed in the MR suite, and we're utilizing real-time image guidance. Imperative to a successful procedure is the pre-op, the intra-op, and the post-op imaging. All of these things are critical in terms of planning the treatments and then, of course, evaluating your outcomes. As a reminder, this can be performed either in a diagnostic MR suite, or if your program has an intraoperative suite, that is also feasible, as are the varied magnet strengths. So this can be done at 1.5 and 3 Tesla field strength. And then just a quick perspective on my background. I'm a neuroradiologist in Nashville, Tennessee. I'm the co-director of a program called Unity, which is prospective. It's multidisciplinary, and it's a collaborative approach to neuro-oncology, both in the brain and the spine. And LITT is really just a remarkable tool that we've added to our arsenal for the treatment of brain tumors. And we think of LITT as a modality that is both diagnostic, in that biopsies usually precede the therapeutic phase. So it's both diagnostic, it's therapeutic. And as we approach LITT, we have kind of 3 distinct phases. We've got our preoperative plan, we've got the intraoperative assessment, and we've got the postoperative surveillance. And this is just a quick movie just demonstrating a GBM that we treated in the dorsal brainstem. And you'll recognize this as the mVision treatment console there. So let's start by talking about just the preoperative planning phase. And this is a coronal T1 post-contrast image. You can see there's a high-grade appearing lesion that is centered there in the thalamus. And you can see the fiber tracts have been burned into the image. So in terms of our preoperative planning, we will acquire a routine brain without and with contrast. And that typically includes a 3D T1, both pre and post contrast, in addition to the diffusion weighted series, the diffusion tensor series, the flare T2, and then of course our volumetric post-CAD T1 series. So let's step back from the protocol and just talk about what are our objectives just in that preoperative planning phase. And primarily this is for providing the neuronavigation that we're going to need during the procedure. So imperative is that high resolution volumetric post-contrast T1 series. And equally important, as you can see from the graphic there, is the DTI. Those 2 sequences are paramount. The others are highly useful for a variety of reasons. If your program uses subtraction image analysis, then the 3D T1 becomes very important. In general, a couple of things to consider. the technique. We want this to be, again, high resolution, and able really to plug and play into a variety of the different vendor neuro navigation programs. That might be BrainLab, it could be Stealth. Your vendors at your sites will probably be able to provide additional information in terms of the exact technical parameters on some of the sequences, but in general, we want to make sure we get that PostGAD T1. We tend to use the fast GRE. MP-RAGE is certainly thought of by convention as being probably that go-to gold standard, but I think with time we're seeing more and more programs that are adopting the fast GRE as a part of their protocol. Some variation on that, if by chance you are going to treat a lower grade tumor where there is no enhancement, then you'll want to also include a high resolution fast spin echo T2, and usually about 2 millimeters is the slice thickness that you can, that's about the thinnest slice that you can get to. Okay, advancing into that next phase, so we've briefly touched on the preoperative planning, the day of the ablation. Let's talk about the goals and objectives and some of the technical parameters you'll want to make sure you check all the boxes. So this image, this is actually a coronal PostGAD T1. Again, you can appreciate that high-grade lesion there centered in the thalamus, basal ganglia. And then the treatment cannula is traversing a small punch osteotomy there. You can see the artifact related to the probe placement. And this is crucial in your pre-LITT evaluation to make sure that the tip of the cannula is centered exactly into the lesion and you're happy with that placement. So again, the goals, the day of the ablation, even prior to probe placement, we're looking at all of our sequences, making sure that the lesion is stable, ensuring that nothing untoward has happened in the interval, i.e. has there been an interval stroke? Has the lesional morphology changed such that we need to regroup in terms of our planning? This type of thing. So once we validated that the lesion looks as expected, and once we have confirmed that our trocar is appropriately placed, then we get ready to proceed with the actual procedure. Prior to this, remember, you have already imported your preoperative data. Again, that's that high-res volumetric PostGAD T1, and that should have already been introduced into your neuronavigation software and those images fused in preparation for treatment. Talking about contrast, if possible, we like to defer the use of gadolinium prior to the ablation, knowing that having the availability of contrast post-ablation really is critical for our intra-op or post-op evaluation, but also in terms of creating that initial benchmark that we're going to use going forward when we're comparing all of our subsequent imaging. So every program seems to be a little different. I know that you'll experience a lot of variability in all of these steps, but when possible, I think that it probably is best to defer the use of contrast until after the ablation. Some other technical parameters, if you have intra-op CT, you may be using that modality to place your fiducials or place the patient in a stereotactic frame. We have an intraoperative scanner, and so the patient is pinned in the head holder and fiducials are placed even prior to placement of the bolt and the treatment cannula. Again, reiterating just the importance of the post-GAD imaging. As I mentioned, I think most people think of MP-RAGE as probably the gold standard in terms of tumor imaging, but in our institution, we seem to be using more and more just that fast GRE, and I suspect that that will probably reflect the majority of cases that you're involved in. Okay, stepping forward into the post-ablation imaging. Again, what are our goals and what are some things to keep in mind? Really, the goals mirror that of the pre-ablation imaging. We want to determine, have there been any complicating features? Do we have an unexpected stroke? Is there hemorrhage that's unexpected? Do we have malignant edema? Is there a new mass effect? So first, we're checking off the boxes on our safety profile. The other thing that we're doing is trying to identify the TDT lines, the thermal damage threshold lines. And again, all of this is critical in either that intraoperative scan or your first post-ablation scan. So we want to make sure that we really do everything we can to establish that first scan, knowing that it will be the comparison going forward. Other things to consider: did we actually cover the target? So we want to, again, focus on those TDT lines and look at our preoperative imaging, look at our maps on the treatment console, and really just determine, did we include all of the lesion within the ablation zone. A couple of things to consider just from the technical perspective. Obviously, the probe has already been removed at this point. The exception there, if there's some uncertainty about whether or not the ablation is complete, your surgeon may decide to leave the bolt in place. Again, if your program uses subtraction technique, you'll want to make sure that you do the pre-contrast T1s, and then as time allows, the inclusion of T2 sequences and flare sequences, and we're going to show some examples and talk about the benefit of those sequences. In terms of diffusion weighted imaging, we include that series. It has not necessarily been that helpful in terms of the assessment of the ablation per se, but again, I think it checks the box in our safety profile, and it allows some reassurance that nothing catastrophic has occurred. I think early on in some of our first cases, we were really happy to see that DWI series was pristine, and that there were no surprises, as can sometimes occur. Again, can't stress enough just getting that high res, the volumetric postcad T1. You're going to use this on every comparison going forward, and it's critical. We use that not only in the follow-up setting, but also just determining the overall volume that was ablated, and again, establishing and documenting those TDT lines. Okay, this is a nice slide, just really encapsulating the workflow. And at first glance, it may seem overwhelming, but I think once we dissect this, you'll realize you really already know all of this information. So to reiterate the process, we've got our preoperative phase. The scan is obtained, making sure that we have included those two vital sequences, the DTI and the postcad T1. Again, DWI is useful, as is the 3D T1 pre-contrast if your program is going to use subtraction imaging, and then the flare and the T2. Again, just to reiterate, the day of the exam, those 3D T1 postcad images will be loaded and fused into MVision, and the DTI fiber tracts or perhaps if your program is using functional imaging, those things can also be loaded into the neuro navigation and used for your guidance. Confirmation of the trocar placement, again, we can see that coronal T1, but that can certainly be in the sagittal plane, it can be in the axial plane, and that's just to provide reassurance that we are about to ablate our intended target. The procedure is performed, assuming that the surgeon and the radiologist is happy with the TDT coverage, then our probe is removed, and then we conduct our post-ablation scanning. Again, the timing of the contrast is also very important, and I think as the Monteris team and I have discussed this, it really is important just for internal consistency. At St. Thomas West, it seems that our time interval between the injection of gadolinium and the acquisition of the post-GAD T1 is in the order of about 5 minutes. Every program is nuanced. You'll find that there are subtle differences. I think more than a specific number, I think if you can aim for internal consistency, doing the same thing over and over again, then you will have results that are reproducible. The technologists are fantastic about utilizing time. For example, while that 5-minute interval is transpiring, we're going to go ahead and run the diffusion weighted series. That's about 55 to 60 seconds. We can go ahead and get in a fast spin echo T2. That's about another 2 to 3 minutes. And your technologists will know how to do this. They're all excellent and they're very efficient in terms of packing in those sequences and using the time wisely. So the diffusion weighted imaging, T2 flare, and then the post-GAD T1, again, high resolution, either fast GRE or MP-RAGE, and that's pretty much it on the immediate post-ablation scan. We don't really get too fancy. We just try and keep it efficient and get the sequences that we know we absolutely will need. Okay, so we've talked about the pre-LITT phase. We've talked about the day of the ablation, perhaps intra-op or perioperative imaging, and then now we want to at least address the follow-up imaging. So again, we have goals and objectives, and they really do just mirror that immediate post-ablation scan. We want to make sure there aren't any complicating features. Has there been an interval stroke? Has there been a hemorrhage? Do we now have malignant edema? Is there new mass effect? Anything that might change our outcome or anything that might change therapies going forward. The follow-up imaging, usually we can identify those TDT lines and we can monitor our original images and compare and contrast and determine whether or not we've achieved a therapeutic effect. And again, just is there residual? Is there residual that we didn't cover by the ablation? In certain circumstances, this is almost by intention. Our program is very conservative, and we have adopted the philosophy of a maximal safe resection, or perhaps a maximal safe ablation. And what I mean by that is if we have, let's say, a high-grade lesion in the thalamus, and we are in close proximity to corticospinal tracts, we can push that ablation zone up to the tract where we think we have made a clinical difference, but we're also not going to impair the patient. We're not going to make them plegic for the sake of having a pretty picture or, ablating the lesion in its entirety. So the follow-up imaging, again, that's crucial to assess for whether or not you think there's any residual that either has developed in the interval or that wasn't covered by the original ablation. In terms of the protocol, we use exactly the same as our pre-op. Again, just making sure that we include that 3D T1 volumetric scan. For us, it's BrainLab is the vendor that we use, and so we include the two vendor-specific sequences that they recommend, the T1 PostGAT and the FSE T2. In terms of the time frame of follow-up imaging, we're a little bit different just having access to intraoperative imaging. And so in a lot of the cases that we do, that intraoperative post-ablation scan, you could really think of that as your 24-hour pre-discharge scan. And I think that that's invaluable, whether conventional tumor resection or neuroblade. That 24-hour post-procedure exam that's pretty well accepted as gold standard and best practice. Beyond that, it gets a little more routine, usually a 1 month, a 3 month, a 6 month follow-up. If things are going well, you can expand that to a 1 year time frame, knowing that at any time along that that journey that the patient is making, we may have to modify that. If there's a clinical change, then certainly you can get more immediate imaging, a month or 6 weeks, depending on the patient's clinical course. So that pretty much gives us a shell of that pre-treatment phase, the day of the procedure, and then a rough guide on follow-up imaging. I think we're going to jump into rather some case presentations, and hopefully this is going to cement some of these things that we've been talking about. This is, we'll say, a 70-year-old female with right-sided weakness. Unfortunately, a scan was obtained, and you can appreciate this is a high-grade lesion right in the posterior limb of the internal capsule, the thalamus, the basal ganglia. So, the real estate is crucial, unfortunately. So we've got a coronal T1, an axial T1. Both of those are post-contrast, again, just demonstrating a high-grade lesion. The appearance on T2, as we know, with high-grade lesions, specifically a GBM, you do have peritumoral edema, but unfortunately, there's always a non-enhancing tumor component. What I think is interesting, just to make note of, is this is an axial image from the diffusion tensor set. And you can appreciate that the corticospinal tracts, they are displaced. And as those are displaced, the arbitrary color that's assigned to that directionality slightly changes. So you know that physiologically, those are abnormal tracts. We also know that with these higher grade lesions, sometimes the tracts are displaced, sometimes they are disrupted, sometimes they are obliterated. But I think this is just a nice example of that displacement and altered corticospinal tract that runs right through the thalamus. Okay, this is the same patient. This is actually 2 sets of images with our DTI burned in. And these are the cumulative TDT lines. And when we look at these, we typically think of the yellow threshold as our boundary for safe ablation. If we're being very careful to approach but not extend past an eloquent fiber tract, then we will pay special attention to that yellow TDT. We know that, or we think of everything within the blue TDT lines, we think of that as ablated tissue that is no longer viable. Okay, again, this is an intraoperative set of images that was attained immediately after the ablation, and I hope that you can appreciate the cursor there. This is just the DTI, and again, I don't think it adds a lot of value, but it is a reassurance that we haven't had an unexpected large infarct and we can provide that information to the family as well. So I do think it has value in terms of safety profile. This is an axial T2 FSE, and you can appreciate a small amount of air from the biopsy itself, as well as disrupted tumor, degrading tumor products, hemosiderin deposition. So a very heterogeneous appearance on the T2. The T1 post-contrast, again, similar story. We've got air from the biopsy. We've got coagulated tumor within the cavity. And with time, I've found that post-ablation zone can have a very heterogeneous appearance. You can make out a thin rim of hyperintensity, and that actually is the TDT line. And we will painstakingly compare the thresholds that we see on the Monteris workstation with the images on PACS, and really just validate that what we're seeing post-procedure is what we would have predicted by those TDT lines. We include a flare. It's a little bit of a bonus, and I think it's nice to include. I don't know that it's been described, but I have observed a very thin hypointense rim on flare. And I believe that actually is representative of the TDT line as well. So again, this is our GBM. This is immediately post-ablation. And I've included this slide for a couple of reasons, just to remind you that we can see subarachnoid hemorrhage post-procedurally. We can see subdural effusions. Sometimes they can be quite large. We can see subdural hematomas in and of itself. None of these things are really catastrophic, but they shouldn't surprise you, and you should expect to see them. Just from the imaging perspective, anything that we see on flare that is hyper intense, for example, this is material interdigitating a sulcus there, we really only have a few options. That could certainly be subarachnoid blood. We know that proteinaceous debris can cause signal hyperintensity on flare. Purulent debris, of course, that's not going to be the case in this circumstance. And then finally, patients that have a high PO2, actually you can have a diffuse intensity on flare in the subarachnoid space. So I've included that slide just to remind you that you can see subarachnoid hemorrhage, you can see a subdural hematoma, you can see subdural effusions, and at times they can be large, and that doesn't necessarily mean that the patient is at risk or something devastating has happened. They just can occur. 24-hour post-ablation, very important. This is just an image bank of that time. Again, the diffusion weighted imaging, you can start to appreciate a slight blooming of the ablation zone, and we can see that on T2 and flare as well. We have included a pre-GAD axial T1. You can now appreciate there's hyperintensity in the cavity, and we know that reflects degrading blood products. Again, we still see a little bit of air. That should not give you reason for concern. It's expected. And then this post-GAD axial T1, really just a nice example of what you should see. You've got enhancement of that TDT margin, enhancement of the areas of the lesion that were treated. And within that zone, we make the assumption that tumor is no longer viable. And by imaging, of course, it can be very heterogeneous. Okay, this is our same patient. We're a month out now. Things have gone well clinically. And this is just a series of 3 images that I wanted to highlight some of the changes you'll see. And specifically, I think we had a question about, the learning curve. And this is an example that I think we should spend a couple of seconds on. We've got a lesion that is hyperintense on diffusion-weighted imaging. On our T2, we see that the lesion has a hypointense rim. Centrally, it's hyperintense, and there is increasing edema, and we have enhancement. So with no history at all, you would be concerned that this is a pyogenic abscess. And I think that's one potential pitfall that your neurosurgeons and your radiologists may struggle with that early interpretation. This is not an abscess. In fact, these are expected changes, but there is enough of a crossover that it's at least worth mentioning. This is a fairly common pattern post-ablation. Again, same patient, just underscoring at 1 month, quite a bit of variability. On the T1 specifically, we can appreciate hyperintensity. We know that that's probably extracellular methemoglobin, degrading blood products, early mineralization, something you might see in cortical laminar necrosis. But again, this is the expected appearance about a month out after the ablation. So we've got increasing edema. We have enhancement. Sometimes it's smooth, sometimes it's shaggy. We will often have regions of restricted diffusion within the ablation zone. And in reviewing our pre-contrast T1, we can usually confirm the presence of blood products, and that reassures us that this is not an abscess, but actually just expected post-ablation findings. We've included this slide, again, just to show you the variation in the ablation zone and its internal characteristics. So the top panel is post-GAD axial T1, and then our bottom 4 images are all T2. And you can see as we go cranially to caudally that there is variation in the appearance of the degrading blood products, in the appearance of the tumor, and in the surrounding edema. Again, we're 1 month out, and at this point, the edema continues to expand somewhat, as does the ablation zone itself. The patient continues to do well. We're 3 months out. At this point, we note that the restricted diffusion has resolved. We see that our ablation zone is starting to contract on the T2. In terms of the edema surrounding the ablation zone, this is somewhat variable. You shouldn't be surprised if it's continuing to expand. You also shouldn't be surprised if you begin to see some of that contraction. I think that variation may depend on the underlying lesion as well. And then the enhancement profile, you may have ring enhancement, you may have areas of central enhancement, but at 3 months, you'll start to see some changes and some contraction of the lesion. Okay, this is still at 3 months, again, just included to show you that variable appearance of T1 within the ablation zone, both pre and post contrast. And then this is just a nice summary slide showing the evolution of a lesion after ablated. We see the high-grade lesion pre-ablation here to the left, immediately post-ablation with our post-biopsy air degrading blood products, devascularized non-viable tumor, and then that subtle rim of enhancement, which is the early signs of the TDT line. 24 hours later, we have increased conspicuity of that, that boundary. 1 month out, 3 month out, you can see that the central portion is starting to contract, and the enhancement and the TDT lines are really becoming much more amorphous. Okay, we've got some cases that have been submitted by some of our colleagues, and obviously gratitude to those programs, and we'll run through a couple of these as well. This is a GBM, and this is from Dr. Barnett in Cleveland, and again, just a very elegant demonstration of what to expect. We've got a high-grade appearing lesion prior to the ablation. There's necrosis there. There's obvious vasogenic edema. You know that there is also non-enhancing tumor, within that mesial frontal lobe. Again, post-ablation, 24 hours out, we can start to see that TDT line, and the internal morphology is varied. 3 months out, things are starting to clean up a bit, and you've got contraction of the ablation zone. The enhancement is resolving. The vasogenic edema is resolving. And this just continues on. We've got a wonderful 7-month interval, 1 year out, and then amazingly, 72 months later, we've got just minimal enhancement. I mean, this is really just very inspiring to see, a high-grade lethal lesion like this 72 months later, and all we have is just minimal enhancement. That could easily be gliosis. It could easily be a small area of granulation tissue. It could easily be a small area of radiation necrosis. We know that there probably is tumor that's still there, but just, again, a very elegant demonstration of what LITT is capable of accomplishing. This patient would probably have leg weakness, right leg weakness. You're there in the precentral gyrus. Some of that edema extends anteriorly into your supplemental motor area. And so this might be a patient that I would expect to get slightly worse. After the ablation, you're really hitting them kind of hard there on the supplemental motor area. But with time, we know that that will resolve and that function should return. Okay, again, the courtesy of Dr. Newton at Memorial. This is, as you can see, a 36-year-old female, and this lesion was biopsied. The diagnosis was made, and the patient was treated. And it's an excellent workflow on some of these lesions. This turned out to be a grade 3 anaplastic astrocytoma. It is a methylated MGMT tumor and IDH1 mutant. So this patient was ablated and then received conventional therapy, which would include Temodar, obviously a brand name, but we'll use Temodar just because everyone's familiar with that, in addition to radiation. And so back to the pictures, you can follow the yellow TDT lines, and these have been burned into each image. And again, a very elegant demonstration of what LITT is capable of producing. You have a 3.5 centimeter lesion immediately post-ablation with our TDT lines burned in. 4 days later, we've got expansion of the lesion. We can see that edema has increased somewhat, as has the overall size of the lesion. We expect this. This is not a complication. At 3 months, similar picture. The lesion is continuing to get bigger. The enhancement is more robust. The rind is getting thicker. There's mass effect. And you should not think of this as disease progression. I think this is a fundamental key that you should definitely take away, is that after ablation, these lesions will often increase in size, the enhancement can increase, the edema can increase, the mass effect can increase, and we expect this. In terms of how much is too much, about 30 cc's, I think, in terms of volume, is probably that upper threshold of safety. Obviously, there are several factors that go into that. If this is an elderly patient that has volume loss, they can accommodate that lesional expansion much more than a 20-year-old who has, excuse me, who has an otherwise normal healthy brain. So 3 months, don't panic at this point if the lesion seems to continue to expand. One way that we think about this, in a high-grade lesion, let's say you have a GBM and the patient has undergone resection with conventional therapy to include radiation and chemotherapy, specifically Temodar. 3 months is that time frame where we start to see pseudo-progression. So in some ways, you might think of this as a form of pseudo-progression. The tumor is responding to the therapy, but this doesn't necessarily mean that any of the treatments have failed. Okay, 1 year, 2 year, 3 years out, again, amazing result. You can appreciate that the lesion is now contracting, and at 2 years is actually contracted beyond those original TDT lines, and then at 3 years you're left with nothing more than just small area of enhancement there by the ventricle. Okay, another elegant example of a anaplastic astrocytoma. This patient had undergone stereotactic radiosurgery and developed radiation necrosis. This case comes by way of Dr. Mohammadi, again at the Cleveland Clinic. And again, the picture really tells the tale. There's the pre-ablation volume, the immediate post-ablation appearance, our 1 month follow-up. In this case, by 4 months, you've got a nice contraction of that enhancing rind, and it's contracted well beyond the original TDT. And this lesion continued to contract. At 14 months out, you've got nothing more than minimal nodular enhancement. And again, that nodule, we don't know exactly what that is. It's probably a mixed population of cells to include indolent tumor, radiation necrosis, granulation tissue. But the important thing is, as we surveil this, there's no interval change, and that's reassuring. Okay, this case looks very familiar. I think this is one of ours from St. Thomas West, and it's an interesting case for a couple of reasons. This was a patient that had a biopsy-proven oligo and was treated with conventional therapy and ultimately developed radiation necrosis. In that top row, this is the flare. The bottom row is your post-CAD T1. And in this patient, we actually had areas that were suspicious, both enhancing and non-enhancing. So our biopsies, as I recall, proved radiation necrosis, but I suspect in reality there probably was some residual tumor there as well. And you can see this particular gyrus just looks a little different. You get the sense that it's more of an infiltrated process than the indistinct T2 here that probably reflects a post-treatment change or even edema. So we ablated this lesion there, mesial, frontal lobe, 2 different trajectories, hoping that we could expand the total volume treated. And then as you can see, by 24 months, really just nice contraction of the ablation zone and decreasing extent of non-enhancing T2 and flare. The story does not end there. This patient, because of the field of radiation, ended up developing necrosis in the contralateral mesial left frontal lobe, and so why not go for the third ablation? So we can see that there is an enhancing lesion associated with T2 there at 6 months follow-up that was biopsied and again proven to reflect radiation necrosis. We've got our immediate post-ablation imaging, and then with time, this lesion continued to contract as well. Okay, we've got a couple more that have been submitted by some of our colleagues. This is Dr. Prabhu from MD Anderson, and this is a primary breast with metastatic disease, treated conventionally and unfortunately recurring. Again, the pictures really just tell the tale of success here. We've got an enhancing, high-grade appearing lesion. I might have wondered if this would be necrosis, but often it is a mixed population of tumor and radiation necrosis. At 1 month, we've got that blooming of the ablation cavity and the edema that sometimes gives us reason for pause. But if you can be reassured that this actually is an expected effect and just stay the course, then we see that these findings do contract with time. By 5 months, the lesion is contracting, and then by 9 months, we have nothing more than about a 4 to 5 millimeter enhancing nodule. Again, the nodule, we follow that with time, and we're reassured when we see no changes. Similar story, another patient that comes from UCSD. This is a case that Dr. Chen has submitted, and this is a primary colonic malignancy with metastatic disease to the thalamus, treated conventionally and unfortunately recurring. On the pre-ablation imaging, you can see there's quite a bit of edema associated with this, all vasogenic edema, and then relatively homogeneous enhancement. 1 month following the ablation, again, we expect to see this. This does not reflect a treatment failure, but rather just that expected expansion of the ablation zone and increasing T2, which in the case of a metastatic lesion probably reflects edema. In the case of a high-grade glioma, probably edema, but we do know that there is non-enhancing tumor that can coexist in some of those areas. And again, an excellent result. By 3 months, we've got contraction of the lesion. By 6 months, barely even detectable. Okay, same story. This comes from Dr. Chang from Yale. We've got a patient that had metastatic melanoma, and we've got a favorable marker, the V600E substitution, BRAF positive. That is a marker that is favorable for treatment to include immunotherapies. And so you can see we've got a lesion there that was treated with stereotactic radiosurgery. That lesion was taken up to 18 gray. And we don't have a 1 month image, but I will tell you that some of these small metastatic lesions that we treat with radiosurgery, you can expect expansion of the lesion. Again, that does not reflect a treatment failure, but kind of a post radiosurgical sunburn, if you want to think of it that way. And at 3 months, as expected, this lesion has melted away. The patient was surveilled, and by 12 months, we've got a problem. At this point, you've got enlargement of the treated lesion, heterogeneous appearance, shaggy, thick rind of abnormal enhancement that's associated with increasing flare and mass effect. 12 months, for us, we think of that as really good for radiation necrosis. Again, stepping back to post-treatment phenomenon, if you think of pseudoprogression around that 3 month time frame, radiation necrosis I like to think of somewhere around 6 months, but 12 months certainly fits into that time frame as well. This is a good use of PET, and basically that just demonstrates that this is avid for FDG. A hot lesion for us, we would think that that could be viable tumor. Regardless, it needs to be treated. And so a dual trajectory ablation was performed. By now, you're very comfortable with the post-ablation appearance. And, as you can see, with time, this lesion continues to contract. 3 months, 6 months, really just an outstanding result there. Okay, this is another example of radiation necrosis, and I think this also comes from our Yale colleagues. This is a male that was 75, had metastatic melanoma, unfortunately had a different molecular profile, BRAF wild type. The patient had 2 separate lesions. He underwent stereotactic radiosurgery. 2 months following radiation, you can see a really nice contraction of that occipital lobe lesion. The patient was started on immunotherapy, and then 4 months after ablation, presented with confusion. Imaging was obtained, and we see a worrisome lesion here. We've got expansion of the ablation zone. We've got quite a bit of enhancement, somewhat shaggy, and there's an associated increase in flare hyperintensity. So at this point, we need to know what is it and what can we do. The patient was started on steroids to temporize the clinical symptoms, and then the patient underwent biopsy and an ablation. And you can appreciate by 2 weeks, we're starting to get control of the lesion. You can appreciate on flare that there actually is a hypointense rim here. And I believe that to reflect the TDT line. The lesion has expanded somewhat, but I'm reassured, overall by its appearance and by the presence of that hypointensity, which I think reflects the TDT line. By 3 months, we've got this thing back under control. The enhancement is decreasing, lesional size is contracting, and our flare is also decreasing. Okay, just a couple more cases here, and then I think we'll probably move into some questions. Another familiar case for me, this is a patient that had breast cancer with intracranial metastatic disease, treated conventionally, and developed radiation necrosis. Obviously, this could be tumor, but just looking at that initial post-MT1, I can tell you that, to me, that really, I would expect radiation necrosis, quite a bit of edema. So this patient was biopsied, and a 2 trajectory ablation was performed. By 1 month out, we've already got improvement. Really just a much cleaner appearance of that ablation zone. You can see the 2 little dots within representing the probe tract. We've got our flare under control. That's beginning to regress. And with time, this process continues. The contraction of the ablation zone and then the resolution of abnormal flare, such that by a year out, to me, this has the appearance of a controlled post-ablation lesion. We've kind of come full circle. I've included this case just because I think it highlights, really some of the power of LITT. This is a previously unresectable lesion. At best, this patient would have gotten radiation and chemotherapy. And now we have a novel technique to treat this. And, this is a dorsal brainstem lesion. You can see that it's obviously high grade. You can appreciate our TDT lines. We've sculpted, that zone of ablation to encompass the entire lesion. We've avoided our eloquent tracts that have been burned in, and really just a nice example of what LITT can accomplish. These are just some companion images with the pre-ablation appearance our probe placement at about 100 minutes in, although somewhat scary in appearance, a very controlled situation, and then our post-ablation images demonstrating really no complicating features at all. I'm really appreciative. I'd like to express my gratitude again just to Monteris and those of the users that are new to LITT, or as you see more cases, it is really just fascinating. And it is such an elegant and novel way to offer something to these patients that previously we did not have. And, you're going to see patients that just cannot tolerate a craniotomy, going to see the patients that have unresectable lesions. All of these things. Maybe they can't tolerate, anesthesia for, 2 to 3 hours to have a formal resection. And it really is just a game changer. And, it offers, another way to give these patients time, to give them hope. And, I know at St. Thomas West, it really has changed our program.